So, honorable ministers, distinguished guests, dear colleagues, we are ready to start our first panel, Partnership Building for Research and Development, and it gives me a great pleasure to invite two co-chairs on the stage, Dr. Tonka Varleva, Director of HIV Prevention and Control Program with the Ministry of Health Bulgaria, and well-known professional, Mr. Peter O'Donnell, Associate Editor from European Voice. Welcome, and please take over the first panel.
How nice to be applauded. How very nice of you. Journalists don't usually get applauded. People usually throw things at us, so thank you very much for that. My name is Peter O'Donnell. I'm the Associate Editor of European Voice. It's my pleasure to be one of the co-moderators today with Tonka. Just to say that this is also a session, we're going to have the keynote speaker in a minute, but it's a session where we have an excellent panel, but everyone is involved. It's your meeting as much as the panelists, so we also want to do it in a way that you feel happy about asking questions. But first of all, can I ask Dr. Tonka, we have so many introductions here, but please welcome Dr. Tonka Varleva, Director of the HIV/AIDS Prevention and Control Program with the Ministry of Health Bulgaria, who's going to introduce the keynote speaker.
Thank you, Peter. Good morning. Dear guests, dear colleagues and friends, I have a pleasure to invite Dr. Lucica Dutu, Head of Stop TB Partnership. She will present new scientific developments in TB control. Dear Lucica, the floor is yours, please.
Thank you very much, and good morning. Actually, I will present something more about, like, do we have the right tools in fighting for TB? But before that, I want to thank all of you for being here in the room. I want to thank, more than anything else, to the Latvian government, to the Latvian minister, to Mr. Piebalgs, and to the team of Minister of Latvia and Agnes, for making this a reality. And for us working in TB, and here in the room, half of the room, I think we know each other for 10, 15 years, we, for whatever reason, lack opportunities to have a high-level event on TB. But we never give up, and we continue doing our work. And I think, as a friend of mine, Ivan Solovic from Slovakia, said today, it requests a lot of passion and a bit of craziness to work in TB, because we are doing an uphill battle. It's a difficult disease. It's a bloody mycobacterium, tuberculosis, that it's smarter than us. Funding is not coming. Our colleagues are not that excited to join our specialty. We are not reaching as high in the governments as other diseases, but we don't give up. So I hope these 2 days we are not only not giving up, but I hope we will have the power in influencing the policymakers and decision makers that will be here. So I'm speaking today about the importance of research and development in TB. And to my surprise, when we speak about eliminating TB, it's not that it's something new. A very honorable group of scientists met in 1908, and Mr. Robert Koch was there, and very excited by the discovery of Mycobacterium tuberculosis. They all discussed and pledged that they will eliminate TB in 25 years, since 1908. I think they will be very disappointed to see where we are right now. And where we are right now, it's here. And you saw very good figures from our colleagues from ECDC. The sad reality globally is that we have 9 million new TB cases, and estimated by WHO, out of which, unfortunately, we are able to diagnose just a little bit less than 6 million, which means that we have a gap of 3 million people that are out there, undiagnosed, undetected, untreated, or treated but not really reported. And what is tragic is not only the individual stories of each one quietly suffering. But what is tragic is that each of the persons that has the disease can infect up to 15 people per year, as we know. And it's not only infection with TB, it's infection with MDR-TB, it's infection with XDR-TB. As you can see, there is an estimated almost 500,000 MDR-TB cases globally. These are just new cases. So those of you here, and I know you all, and my own country, we have, in addition to these cases, at least 200,000 more that are the chronic cases. But speaking just about the new ones, as you can see, just a little bit less than 100,000 were diagnosed and enrolled on treatment, and you heard already from the ECDC colleagues that just half of these are able to be successfully treated. And we have 4,000 deaths per day. So as you saw already, we, in terms of trends, in terms of the global trends, it's downwards, right? So there is a decline in incidence, there is a decline in mortality, there is a decline in prevalence. And you heard as well from the colleague from ECDC how long it will take to achieve our targets. This is a slide showing the global current incidence, which is 125 per 100,000, and this is the end TB target by 2035 to reach 10 per 100,000. So for everyone here at global level, the end TB target is not speaking about eliminating TB. It's speaking about bringing the entire world at the level of the developed countries at 10 per 100,000. Between 10 and 1 case per million, which is the elimination, it will take a long time to go. We have a decline globally. It's 1.5% per year, which is very slow. You saw that it's 3% it's 13% in the European region. But if at the global level we continue to decrease at the same level as we are decreasing now, it will take us up to the year 2180, not to eliminate TB, but to end TB as a pandemic, as it is in the end-TB strategy. This is a slide that was very many times presented. It's produced by WHO colleagues in Geneva TB department. And as you can see here, the aspiration is to go at a much higher rhythm, as already you heard, for the European region than we are right now. What will make or break this deal? It's the existence and the chance of getting new tools. Without the new tools, without a diagnosis and a treatment and the vaccine that are different than what we have right now, we will never be able to reach the targets that we proposed by 2035. This is how we work. And, you know, the reality is that I spoke about Robert Koch. You know, if Robert Koch will come in the room here, he will have actually a pretty good conversation with a lot of us, because we are still using largely the smear microscopy for the diagnosis. And we are using a vaccine discovered in 1921 that is largely ineffective in terms of adults and has a lot of issues in terms of the childhood TB as well. So our guns look like this, and there are limitations. And I would like us to think of the limitations of our tools, not necessarily because they are not sexy and, you know, like any others, but the limitations in terms of a patient. Because if you are a patient coming from a village and you are trying to get diagnosed your cough, leave aside, as we heard from Marina, the lack of thinking about TB of doctors in many places and therefore pendulating for months between different diagnoses. Leave aside that, which is also related to the fact that, you know, we don't have a point of care tool. But even if you get to a place, you will get a smear microscopy in most of the cases. Then you have to come back over a few days, after a few days, to get your diagnosis, and hopefully you can get enrolled on treatment. The treatment is based usually on a smear microscopy, because if you have to do a culture, you will have to wait 2-3 more months, and in the meantime, you will follow the first treatment prescribed. And in many cases, after the 2-3 months, especially in the European region, you will realize that it's actually an MDR-TB. And as you heard, then you go back home with 15,000 pills to take, with all their implications. And leaving aside the financial burden, which is an important piece of it, I want all to think about the human burden and the side effects that people have to take, and the fact that sometimes you have to face deafness, psychiatric conditions, and huge nausea, which will make you interrupt the treatment. God forbid to have a child that is, that you probably or somebody infected, because for children with TB, for those of you working as clinicians, we know what a drama it is right now, not only to diagnose childhood TB, but also to treat. We are still giving pills that mothers have to break and mix into a tea and give to a kid. And if living all the time, those of us who were dealing with children, was it enough? Was it good? If the kid is vomiting, what do we do? So we are having, as you see here, a lot of challenges and limitations, and this is related to the treatment and unpacking what's happening currently and what is the dream to go forward. All the slides will be available for circulation because I have some great backup slides explaining very clearly the entire pipeline for diagnosis, for a vaccine, and for the treatment. But here it looks how far we are in the drug-sensitive TB, in the MDR TB, the TB HIV co-infection, latent TB infection, and pediatric TB from what we should have as the right tools to fight this disease. This is the cost of inaction. It was mentioned before. As you can see, unpacking the costs for TB treatment, for MDR and XDR TB, it can go up to $500,000 actually. These are the figures we have, dollars. And you can see for XDR TB treatment, including the productivity loss piece, and as well the direct treatment costs, including as well hospitalization. There are things that we can do with the current tools much better. And I'm not entering into this. This will probably be touched in the next panels. But we cannot move the needle without having a new diagnosis, a new treatment, and a new vaccine. And to get this, we need the enthusiasm of people involved in research and development, researchers and institutions themselves, as well as the enthusiasm of the donors to ensure, and the country driving these agendas, in order to ensure that we are able to have these new tools in a time frame that is important. Any delay that is happening now, and the more funding is delayed to come, the more the horizon of getting the new tools will take. We all dream of a diagnosis tool. We need something, point of care. What do we mean? We mean something that is rapid, that it's accurate, that needs a small sample, that it's easy to obtain, that can detect drug-resistant TB, can be used by health workers, and can be portable, and people can use it and take it with them. We are not yet there. I will tell you where we are right now, and we know where we are. We are not yet there, and therefore people still have to go. We still use smear microscopy a lot, very much, not only in this region but also globally. So we still need to go there. This is the fine colleagues who supported me into putting the 5-year vision for TB diagnosis, the first point of contact, further workup at the treatment and dedicated unit, and without forgetting the importance of surveillance, quality assurance, and training. A new TB vaccine. I will leave you just with a slide showing that in just 8 high-burden countries, by introducing a new vaccine, it could avert more than 100 million lives of TB by 2050. There is my intimate belief that without a vaccine, we will not see this changing. The challenge we have is that we will not have a vaccine by 2020. Very likely, we will not have one by 2023. And in the meantime, we just need to continue push and not lose the hope and the focus on working on a new vaccine while we are implementing what we have right now in terms of the other tools. You heard about Marina's story, and this is where we stay in terms of pills, and I'm sure that other members of the panels will go to this. And the hope is to be there at the aspirational goal, where you have few pills to be taken over a 2 weeks period that can address TB and MDR TB, that can be easily taken by HIV-infected people, and as well will have pediatric combination. What do we have right now? In terms of diagnosis, I think you are all familiar with the expert machine for the rapid MDR-TB diagnosis, which is an awesome step forward, and I want to thank all of you rolling out the expert machine and using it. It's a luxury that we didn't have of getting a diagnosis for TB in 90 minutes. We have 2 new drugs, delamanid and bedaquiline, that are adds-on to current regimens for MDR-TB, but we all hope that with a bigger rollout and a bigger uptake, we will see better treatment outcomes, because it's unacceptable these days to have, in countries like mine, just 30% of people put it on MDR-TB successfully treated. Just 1 in 3 that has a chance not only to be tested for MDR, not only to be diagnosed, not only to be enrolled on treatment, but to be successfully treated. There are just 6 new chemical entities in the late-stage clinical development, and only 2 tested in combination regimen. We put it here just a comparison with another disease where there are 40 like this. So we need to think collectively why we miss the big push from the researchers to invest into research for TB. One thing might be the money. The global plan to stop TB says that we need $2 billion for research and development. The 2013 report that we produced together with Treatment Action Group from the Stop TB Partnership shows that it was below 700 million that we had as investments. It's not that it's below 700 million, but versus the previous year, the trend is downwards. Awesome. So it means that we still have a significant gap of $1.3 million. This is an unpacking, what is available by the different new tools that we need to have funded. Just a little bit of what's happening with the funding in Europe. Actually, we are here coming from the European region, right? And we are all very proud because actually Europe should lead in a lot of things. As it used to lead, the buzz around TB was what? France, was Germany. That's where the entire knowledge about Mycobacterium tuberculosis and the drugs and everything was coming. For whatever reason, Europe is lagging behind. Of course, among the top 10 R&D global funders, you have UK, the 5th, you have EDCTP, the 7th, and the European Commission. And within the European Commission, you see the respective funding. But if you look with the comparison with the US spend, which is at the level of 250 million a year, you will see that it's not enough. It's actually a pretty pale picture. So we are here today, and again, I want to thank really deep to the Latvian government. Latvia is well known for 2 things, and they had really the strength to look at the MDR-TB problem in their eyes. And working with a fantastic team led by an expert that I think half of all this room went and got trained by Vaira Leimane, they agreed to look over the MDR-TB and try to fix it. And they are fixing it, and they fixed it. So Latvia is one of the examples in the countries in which properly addressing and investing in MDR-TB will make a difference. But Latvia also hosted all of us here under the presidency mandate. And we are going out of here tomorrow with a Riga declaration. And what I really think is extremely important for all of us, I'm tired of declaration. You remember the ministerial meeting in Berlin, the Beijing meeting on MDR-TB? Declarations are awesome. We need to follow on this. This should not be an awesome 2 days in Riga with a great declaration unless there will be the next steps forward, and we have some next steps saying there. And you know that this is the research and development statement there, saying that we need to strengthen collaboration and research and development for new tools and embrace innovative and patient-centered approach to TB prevention and care. It's very vague. It's very broad, actually. And I think what it means that we should all push, not only our own governments, but the Commission as well, in investing more in TB research and development. And here are some opportunities. I don't think I'm going to go over all of this. There is the European and developing countries clinical trials partnership mechanism. It is good. It has to be further developed. But outside the EDCP, the Commission should develop some channels for funding TB research within larger programs. We can think of more accessible systems allowing non-profit product developers to take the initiatives. Why not think of having some pooled fund for countries to develop capacities for trials and testings and move forward into late-stage research? These are just some things that are opportunities if we are able to grasp them and to run with them. But it needs as well the political commitment and as I said, the political attention. So Robert Koch said that in 1908 that it will take them 25 years to eliminate TB. I don't know if you know what he will say if he was here with us today, having, some new drugs coming. As you know, we have some combination drugs, the PAMZ in late clinical trials phases. We have a Mycobacterium tuberculosis being able to be detected by the expert machine. So I think we can have the horizon much closer to us. So very often, and that's, we forget why we work, and at least some of us. Those of you being in the clinics and facing the patients, you realize this much more. And this is Agnes, and she succeeded to, she got cured from TB, as we have here Marina. And the individual stories are the ones that are the most important. And the individual efforts of each of us are the most important in pushing the TB agenda forward. Research and development is not easy. And sometimes we should look at our colleagues working in the research arena, and sometimes, or very often, they are frustrated. Is not, especially research in TB, is not the sexiest area in which you can do. They need our encouragement and support, and I think we need to do a very good bridge between those that are doing research and us from the TB programs and the governments in pushing forward for the new tools that we need. I don't think we have the tools to defeat TB. I don't think we will do it without having the tools to defeat TB. So it's 2015, and it's time to take some action. Thank you.
Thank you very much, Vucica, about excellent presentation and for the good news about two new drugs and rapid tests for MDR-TB. Thank you.
Thank you very much. Yes, indeed. Thank you, Tonka. I'd now invite the panelists to join us on the stage, if they'd be so kind, and we'll move into the examination of the particular challenges in terms of research, meeting some of the difficulties, trying to fill some of the gaps that have been identified in the presentation so far this morning. As I said, the way we're going to do it is for each of the speakers to have a brief sort of opening remarks, and Tonka and I will quiz them to expand their thinking, and they will expand one another. And then we will open it, of course, to you from the floor. Just by way of brief introduction to the panel session, the point that comes out of all the pre-publicity, as it were, for this is that it's supposed to move towards action. And I think this is something that's going to be the real challenge for the speakers. They're all very eminent. They all know what the problems are. Most of us, I think, have a reasonable idea of what the problems are. It's in moving from the problems to how to solve the problems that the difficulty lies. I am not in any way an expert in this field, but I did write a very brief book about TB a year or so ago, in which I concluded Europe has always been good at talking. I know a lot about Europe, not a lot about TB, but I know that Europe's very, very good at talking. But what's still missing is a trigger to fuse the multiple expressions of goodwill and good intention into action. So I certainly will be watching during the course of this morning's discussion to see how much we can move from talking into defining action, and I'm sure that our speakers will be more than adequate to the challenge. We'll take it in the order that's on the program, if you like. So Mike, Professor Mike Catchpole, forgive my familiarity, although you've already had one go. Let's have the essence of your thinking, if you will, about how we move towards action on the research and development front.
Thank you. Oh, it's working, good. It's inevitable that one draws comparisons between diseases and topics, and I think with TB, a parallel is often drawn, or certainly in my mind, with HIV and the difference in terms of the ability to leverage budgets, funding for research, and why is it that we've seen so much more investment over the last 2 or 3 decades in HIV, let's say, compared to TB. And I think one of the major factors there is the visibility, the advocacy for those that are affected. So I think TB, whilst we know that TB can affect anybody and everybody, the reality is that it particularly affects groups that don't have such a good voice in the political arena. The poor, the marginalised, socially marginalised, people who abuse alcohol and drugs, prisoners, migrant groups that may not have a good voice in the countries in which they reside. So I think one of I mentioned at the end of my talk this morning, I think part of the mobilisation, the action, is about developing strong partnerships with NGOs, with charities, those that can help to give more of a voice to those that have TB. I think we also need to be innovative in our thinking about how we promote research. I mean, there are some good examples, I think, from South Africa, the SHIP project about public-private partnership, if I can use that phrase, in investment in research. And I think we also need to map research around the globe, because I think there probably is some duplication that is unhelpful. I think that if we can map research and perhaps develop supranational, regional, or even global consortia that can work together, we will hopefully actually use the resources that we can secure more efficiently. So I think it's about giving voice, it's about working more intelligently together, and really focusing on where we're most likely to have an impact. Thank you.
Thanks for that. If I may, a risk of sort of jumping straight into one of the points of the debate here, which I'm sure other people will also raise. You talk about partnerships. You mentioned partnerships with NGOs and charities, and you mentioned the public-private partnership in South Africa. It sort of seemed to me, but I'm an outsider, conspicuous that you didn't mention industry. Was that sort of deliberate, or were you including that in your references to public-private partnerships?
That was the reference to private-public partnership was about, yes, absolutely.
Okay, fine. Well, I'm sure we'll come back to some of that discussion of partnerships that you raised there. Dr. Manika Balasagaram is the Executive Director of the Access Campaign of Médecins Sans Frontières. Manika, would you like to give us your snapshot of where we should be focusing our attention?
Thank you. I probably just want to start by making 2 points. I think if you want to focus our attention on where we need to go, we need to be very clear about what the problems are. And I want to highlight 2 major problems, at least in this kind of introductory opening that I'm going to make. The first is that, to be very clear, the amount of money we put into TB R&D is woeful. And to give you a comparison, we've already seen the figures that the WHO Global Action Plan recommends $2 billion annually for R&D for vaccines, diagnostics and treatments. Well, that sum is actually very small. If you look in comparison to what a company acquired for hepatitis C drug, that was $9 billion to purchase assets, which was essentially for one drug. And in 1 year alone, they sold $10 billion worth of that drug. That's just for one drug. And then we're talking about a much smaller figure as an aspiration for drugs, vaccines, and diagnostics when we have such a big gap in terms of the needs. And then we only come up with about 30% of that. So you can just start by saying that the aspirations are woeful. And it really means that we need to think seriously about significantly mobilizing much more money into TB R&D. And the critical thing that people need to realize is because there is such a gap in terms of need, we don't have the right ideally the right type of diagnostics for point-of-care diagnostics for patients, especially specific populations like children. We don't have the right kind of drug regimens for drug-resistant TB. Even what we have for drug-sensitive TB, that's 6 months. That's a long time to ask patients to be on pills. Most of us can't even comply to a week's worth of antibiotics. I could go on in that vein, but I think you get the point. And I think what it really means in terms of what the European countries should do is to look at mobilizing much more funding for TB R&D and think about the second point, which I'm going to talk about. And are we doing R&D the right way? Are we spending the money the right way? So I think there is a very good point that was made by the previous speaker in terms of we need to avoid things like duplication. But I also want to make a point that we often don't collaborate enough. And that has, I think, fairly disastrous consequences. I want to make a second point. There are 6 new chemical entities in the TB drug pipeline, as compared to, say, 40 for hepatitis C. 6. Out of that 6, you think that collaboration would be the key because there's so few tools in the pipeline. But in fact, out of that 6 drugs, there's only been work on developing combinations for 2 out of those 6 drugs. We have an incredible situation, which to me as a clinical researcher, formerly a clinical researcher, was shocking that we have 2 new drugs coming on the market. We have no data on how to use these drugs together. I think that is highly questionable in my opinion. So we need to rethink how we're doing R&D. We need to think of a completely different model, more money, put the money and incentivize R&D in a different way, and promote much more collaboration and foster much more collaboration. So we have, in MSF, we have thought a long time about this because I think we've seen this problem from a practical end for more than a decade and a half, treating MDR, but many, many years treating TB overall. And we have really tried to push for a way of rethinking research and development and looking at it from what we call a 3P perspective. So looking at how we can look at much more push funding for R&D, how we can look at different kind of pull incentives, because the kind of pull incentives that we have now are clearly inadequate, but also think about pooling, and pooling in a much broader concept, thinking of pooling knowledge, pooling of data, pooling of intellectual property, and sharing that in the right way. And I think this is a real challenge for us, because I think, to me, this is the key of how we need to move forward in thinking of unlocking the problem we have in TB R&D. The last point that I want to make clear, though, is that I think there is a major issue around access, and this is really linked to how we are looking at the pushing and pooling. And access comes in part of a kind of puzzle. We need to think about innovation, we need to think about access, and particularly for TB and TB drugs, we need to think about conservation as well. And we need to combine those 3 elements and integrate those 3 elements much better to how we're doing it at the moment.
Okay, thank you very much for that. I wonder, I understand there's been some difficulty in this question of access to drugs that are in development, reaching sort of clinical trial stage. Perhaps you could very briefly explain, because I'm sure it's a much bigger subject we can go into in more depth in a minute, but just for anyone who, like me, is not absolutely clear about where the difficulty here lies, with, I think, bedaquiline and the Otsuka one, you wanted to have access to them so that you could you explain a little bit more briefly where precisely the problem is and how that could be solved?
The access problem is manifold with delamidine and bedaquiline. First of all, we don't even know how to use these 2 drugs together. We don't have a rational regimen, so the access problem starts from there. Because you can't just throw these drugs out in the market and expect people to use them without a clue how to use them. So we have to think about developing good rational-based, scientific-based regimens on how to use these drugs, which means we need to do more research and operational research for these 2 regimens, 2 drugs. Secondly, these drugs need to be registered in endemic countries. They need to be made available. So we need much more effort made in making sure these drugs are registered in the priority countries and not just in a handful of countries. And we need to make sure that countries also prioritize, the introduction of these drugs. They're put on national drug lists, and that resources are made available, often through the help of multilateral mechanisms. And thirdly, yes, I think, some of the companies themselves are stuck. I don't really blame them, because they don't really know how to approach an access strategy from this. We have veered from a pricing strategy on the one hand to donation model. And I will critique both of them, knowing full well that, you know, we're in between, you know, a rock and a hard place. And this is why I think we need to rethink the whole system on how we incentivize and reward R&D for companies, and therefore, which is going to be in a way that will promote access and conservation of these drugs.
Okay, thank you very much for that. We'll turn now to Lena Mattison, who's the head of Fighting Infectious Diseases and Global Epidemic Unit. What a big unit that is with such a long title, of the DG Research and Innovation in the European Commission. Lena, would you like to give us your view from the Commission's perspective?
Yes. So, first of all, I need to start saying that TB research has been one of our big priorities, both in the 7th Framework Programme as well as in the new Framework Programme Horizon 2020. And just to highlight that this is not only words but also actions. Just to give you an example, we have just at the beginning of this year engaged the funding of 2 big projects developed for the development of new TB vaccines for the value of 26 million euros. So it is a priority, and I also want to stress that we have spent as much money on TB as we do on HIV and malaria and other diseases. So there was some, I need to say that because there was some negative comments from the keynote speaker. But what I want to address is that what we are also looking into is not only what we invest in, but also how we invest, and how we can invest more efficiently and how we can best use public money. So I want to give you 2 examples of what we have been working on. First of all, we have for some years been working together with the European Investment Bank. We have been and EDCTP, ARES, TBVI, the Gates Foundation, and more recently South Africa, to develop a global TB vaccine partnership. What's the aim of this partnership? It is to get funders together as well as the scientific community to get an agreement of how do we select the best vaccine candidates, and how can we together decide on which candidate deserve to be moved forward in the expensive clinical trials. So a way of hopefully using our money in the best way. And we also hope that this might attract other funders to invest in this area. It is not easy. It's not easy to get people to agree that their baby, their TB vaccine candidate may not be the best, but maybe the competitor. So, but hopefully we will get there. We are moving forward in this direction. Another initiative that we hope to launch this year is another initiative jointly between the European Commission and the European Investment Bank. We are developing an European infectious disease finance facility, which will be based not on grants, not the traditional grants, but actually on loans from the European Investment Bank. The collaboration is, as I said, based on a collaboration between the European Investment Bank and the Commission, because the Commission gives the guarantee. The bank, the European Investment Bank, is a bank and are sometimes reluctant to take risk. So the way it works is that it is actually the Commission's money that are taking the biggest risk, but we hope with the fact that we will share the risk with those that have the loans, that this will also be a way to mobilize other funders, not least the private sector, into bigger investment in this area. So the finance facility for infectious diseases is, of course, not only for TB, but for all infectious diseases.
Okay, thank you very much for that. Maybe, can you just perhaps give us an update, give me an update, because I'm sure everyone else already knows, where we are with the work on the vaccine partnership. I mean, what is the most optimistic prediction you can make for something demonstrably successful to come out of that? I appreciate the effort that you're making. What are the likely outcomes when?
So currently the partnership have been working on getting an agreement of what are the criteria to be used to select the candidates, and this will be presented at the next TB vaccine conference late in April in Shanghai. So it will be an open start of an open consultation, and we are also trying to get other countries involved in this partnership. And of course, the infectious disease finance facility that we are developing is actually also coming out of this partnership, because that the initial idea was with the bank to work specifically on TB vaccines, but working in a very narrow area would not be the right way to move forward in the context of collaboration with the bank, because that would be too risky. So we have extended it to cover not only TB but other diseases. So hopefully this year we will see concrete moves. As I said, it's not easy. It's not easy to get the scientific community to agree. But as I think also ECDC mentioned and others, it is only by working together and agree to share the data you have, etc.
Okay, well, thank you for that. We shall watch expectantly. And now my pleasure to ask Professor Frank Kobelens to give us his view. He's the Chief Scientific Officer at the KNCV Tuberculosis Foundation, and I leave it to him to explain what KNCV stands for. Frank, please, your views.
Thank you, Peter. Well, actually, that is the Royal Netherlands Tuberculosis Control Society, which doesn't have a T in its abbreviation, because it was founded in 1903 when tuberculosis had such a stigma that you wouldn't have that name, that word in the name of your organization. But we focus on TB entirely. So being the only, I think the only full-time TB scientist on this panel on research, I thought maybe let me look back a little bit and try to explain to you a little bit how I think that how we came where we currently are. And I think there are a number of issues that are very specific to tuberculosis, because I can imagine that you are sitting here and thinking, why don't these guys have their act together? Why? I mean, all these other infectious diseases, they have vaccines, they manage to eliminate. We don't have any measles anymore. We eradicated smallpox. We're almost there with polio. Why not tuberculosis? I think there are a number of reasons for that. One is, this is a very hard nut to crack. By now, we know that the Mycobacterium tuberculosis, or the little bug that causes everything, has been with us as the human species, for the past 70,000 years. It migrated with us out of Africa, which means that this bug is perfectly adapted to the human species, and we, as we are sitting here, are perfectly adapted to the bug. We live usually in a peaceful harmony. 90% of those who get infected never gets ill. It's only that unfortunate 10% in the absence of HIV, 10% that becomes ill, which means that we have found a perfect way of living together. And this is what makes it so difficult scientifically to unravel this sort of intimate entanglement between the two. So that is one reason. Another reason is that, and that it probably has to do with all this, is that everything you try to do in tuberculosis takes forever. And that is because the bug grows very slowly. And it is also because there are a number of things that we basically do not know about tuberculosis. When the two great revolutions in medical science kicked in the late 1980s and the early 1990s, which was the molecular revolution DNA revolution, sequencing, and the immunological revolution, nobody thought about TB. TB was the forgotten disease. We actually knew it all. We had a strategy. The disease was only a problem in the very poor countries. We had a strategy that could be rolled out. We had the wonderful microscope. We had these grade 4 drugs with which we could probably treat every patient. So this was a completely forgotten disease. And only since the beginning of this new millennium, people have started understanding that there was quite a bit of catching up to do, and that's now currently happening. And we are actually now only starting to understand the natural history of this disease. So actually we are in the midst of a scientific revolution in tuberculosis. And why does it take so long? It takes so long because we cannot predict who is successfully treated. If, for example, you want to do a clinical trial, which is always needed if you want to bring a new drug to market, it means that you have to do a clinical trial in which, in the end, you compare the proportion of patients who is cured with a control group. And for that, you actually have to wait until these patients have been treated, but also to wait for another year to see whether they relapse. So these trials take forever, and the same is true for vaccine trials, because contrary to most other diseases, we cannot measure the immune effects in the human beings. We don't know whether the vaccine works until we do a phase 3 trial, which means that we have to, there is an awful lot of time and also money going into this, which means that there is a huge need for fundamental research, as well as there is a need for research into the more sort of product-oriented R&D for new vaccines, diagnostics and drugs. Now, how did we get there with regard to MDR-TB? I think MDR-TB is the major headache for Europe. Probably, if there were no MDR-TB, we would probably have dealt with TB more or less as is currently happening in Western Europe, with the increasing, improving socioeconomic conditions and a bit of common sense TB control. Countries have shown that they will usually get there. MDR-TB is the main hurdle. Now, why is this a problem and why is this so hard to crack? First of all, I think there is still uncontrolled transmission of MDR-TB in many countries, especially in this part of Europe. It's been hard to show. There was actually very little evidence, but probably the preferential treatment in hospitals probably plays a role. The other problem is, and that is really where the research needs comes in, is that it is the current treatment, which takes at least 18 months, probably longer, and you've heard these dreadful examples, is simply not scalable. It is not something that you can do at a lower level in the healthcare system. It has to be done at a referral level, which has major consequences. And it also has major consequences because it's so difficult to, these drugs are so difficult to take, so many patients drop out of treatment. So we do need something that is simpler, less costly, and safer and more effective. So now finally, in terms of what I think for what is needed, I think one of the things that we really need to think about is that and then looking at product-oriented R&D, there are disincentives, I think, for industry to get into TB. And that is because the people who are going to buy their stuff are usually poor people. And that is usually not a great incentive. And there is also limitations imposed on the use of new products, for example, new drugs. We are dealing with a disease or a bug that acquires drug resistance easily, meaning that we have to be restricted in the way we use these new drugs. And that's also usually not a great incentive for industry. And we have to think about how we deal with this. And another important step, I think, is that we need to engage academia much more in TB control. I'm personally an academic who spends half of his time in a university and the other half in an NGO. And I think it is one example of the way forward in which we can try and get academic researchers directly involved in implementation problems in TB control.
Okay. Thank you very much indeed for that eloquent denunciation of the difficulties of the present. I will be coming back to ask not just you, but the rest of the panel, whether your challenging analysis renders so much of the rest of the discussion almost irrelevant, since you spell out these difficulties in attacking it with such vigor that it seems almost to a simple man like myself on the outside, I quail at the prospect of overcoming those difficulties, but I'm sure smart people like you will be able to do it.
It's actually great fun, because I tell my students, if you want to win a Nobel Prize, go into TB. There's a world to win.
I knew he'd have an answer to that. Very good. Can the nomination committee please make a note of that? Finally, in this first round of the panel session, Mr. Knut Loneroth, who is medical officer at WHO headquarters. Please, Knut, your views.
Thank you, Peter. Now, being the last giving introductory remarks, I have a feeling that you will quickly get impatient if I don't get to the real action points. But allow me, I just want to, as a bit of a preamble about what we're actually talking about, I have a little bit of a concern when people hear research and development. It's about new diagnostics, new medicines, and new vaccines. But actually, we're talking about much more than that. We're talking about epidemiology, we're talking about health systems research, we're talking about social science. So let me explain. Last year, the World Health Assembly, i.e. all the member states of WHO, endorsed this new global TB strategy. It's the most ambitious global strategy ever endorsed. We're looking at ending the epidemic in 20 years, meaning 95% reduction of TB death, 90% reduction of TB incidence, and ensuring that no TB-affected family has experienced catastrophic costs on the way. Now, we have put, and Lucica showed the slide, an assumption there. In order to get there, within 10 years, we need to have new revolutionary tools. Specifically for getting the incidence down, it's going to be really important to have tools for better prevention. So diagnostics for latent TB infection and treatments for latent TB infection and vaccines, ultimately. Now, if we don't get there, we're not going to reach those ambitious targets of the strategy. Simple as that. Now, in the time leading up to when we get these new tools, we need to focus a lot on how to use the available tools much better, much more cleverly. And this is a matter of understanding the epidemiological, health system, social and economic and political environment of TB and the situation of patients. So we need there health systems research, epidemiology, social science. Let me use the example of MDR TB. We've heard this morning that in Europe, and actually globally, less than 50% of the MDR TB, people with MDR TB are successfully treated. We heard the very graphic story from Marina about her journey. One thing that struck me, so obviously, is this an issue of long, toxic, expensive treatments? Indeed it is, and we need to have better tools, because that would make that journey so much simpler. But it's more than that, and what struck me was that when I heard this story, that what you really need to have entering into this journey, you have to have capacity, you have to have knowledge, you need to know your rights. If you're a lawyer, I think it really helps. You need to have support, and you need to be perseverant. You need to really go and get it. Otherwise, you will lose somewhere on the way. And unfortunately, most people are not in your situation. We've heard that too. The majority are vulnerable groups. So if you have a situation where maybe 50% of your patients with MDR-TB are chronic alcoholics, the majority may be ex-prisoners, homeless, or belong to other really vulnerable groups. How can you overcome those barriers? How can you ensure that these people can be supported to complete the treatment? We have much too little research to understand the barriers, to test out new innovative models of care and packages of enablers that can ensure that that journey is completed. When we get the new tools, shorter, safer regimens, it will be easier, but even then, we will need to understand, and it's also for drug-susceptible TB, by the way, we need to understand what those interventions are most successful and cost-effective in order to get there. So, coming back to the global strategy, it is a global strategy that is conditioned upon research, and therefore one of the three pillars of the strategy is research. So we need to pursue it, and we are now, right now in WHO, as well as with a lot of partners, looking at the operationalization of that. We're developing a framework. Several people on the podium and in the audience have been contributing to that, and I will, later on in the discussion, I can come back to some of the concrete actions. We've heard some of them already mentioned here, but I'm happy to explain more about what that framework is about.
Very good. Thank you very much for that. And just in terms of, without going into great detail at the moment, but you talk about the importance of the application of existing tools. Are there evident examples that you can give of how that is already being implemented? Better targeting, better communication, better focus, better, I don't know, what are the things that spring to mind at the moment as clear examples of where there are better ways that you're aware of improving the use of the existing tools?
Well, first of all, I mean, there are countries, there are settings that are using these tools showing good treatment success, both for drug-susceptible TB and reasonably good treatment success for multi-drug resistance. There are examples out there. There's a multitude of examples, but we need to understand better what works where. So in the European context, for example, if you look at multi-drug resistance, people have started to look at the specific challenges of groups such as chronic alcoholics, drug users, homeless people. We have the example of Tomsk that has developed a full social support program, including patient education and home visits, that is helping to ensure good treatment adherence. And there are other examples like that, but we have not got a really forceful, well-funded stream of work that is looking into the package of services that are essential to support both to get the diagnosis and then to pursue the treatment.
Okay, thank you very much for that. My co-chairman, Tonka, perhaps you already have some reactions to what you've been hearing from the panelists. What's your feeling about the approaches that they're making to this?
Thank you, Peter. I am very happy to be co-chair of this panel. In real, I would like to start that TB is not only health, but big social and economical, demographic and financial problem. And I would like to start that the last years there are a lot of joint actions, and the most of countries in European region have a good treatment success. All we know that it's not easy, and in the same time it's very important we to work very hard to have a new vaccine, new rapid diagnostics and new drugs for TB. Thank you.
Okay, thanks. And maybe Lucica, can I ask you, because I want to get you guys involved in it, but have we got someone with a mic in the audience? Have we got an audience? Are there no mics in the hall for people to ask questions with? I shall have to come down there myself. Here, use mine, and I'm going to walk carefully around the water. I'm terribly sorry I've spilled. This time, I do this often at meetings. Normally, I'm extremely rude and say something that upsets the audience when that happens. It's happened so often now. I didn't say anything rude, but I'm afraid I've spilt someone's water on the floor there. Lucica, your views about what was happening with the panel. Just quick views of responses to their views.
Well, I think, everyone in the panel, gave the multifaceted, it's like a puzzle in which the pieces are coming together. And I think we got a clear picture of where we stay, from the European Commission, what are the level of investments and what is happening, and, the ECDC view of, and everyone emphasizing the need for better collaboration and coordination and for people to come together as a TB community, to the, Monika's suggestion from MSF of thinking different the research. And, in Knut saying, well, we can have the tools, but if we don't have enough operational research to tell us how and where to use it, we cannot do too much. And I think everyone understood where we are. I think what will be very important is to see how we move from here to do all of this. And I think there is a line there which is attention and funding and the willingness of coming together, all of us. I think that the point that I think our colleague from the Commission mentioned, and the fact that there needs to be an understanding as well between the researchers of what compound or what product is the best, and understand to live and let go, and how do we use these opportunities now in putting in place something new that I think MSF spoke about, like the 3 Ps, and Knut said, let's do some more operational research. I think that will be an important piece of discussion.
Okay. Thank you very much for that, and I see the microphones have arrived. Thank you very much. So those of you now who are gathering menacingly under the bunting to ask your questions can ask your questions, because we have 2 microphones here at the front. Nobody wants to come in at the moment? Oh, we do here. Yes, please. Be kind enough to say who you are, because not everyone here, I guess, knows who. And if it's a specific question, a particular person on the panel, do please say so.
Sometimes against each other, because whoever gets that regimen or the treatment is the person that gets the Nature or Lancet paper and the person that gets all the credit. It's similarly true for industry. The reason why they are not working together is, I suppose, their profits are goes to the individual company that wins. Now, I think that the HIV community has sort of got around that, because they managed to get compounds from different companies, and they've managed to create treatment combinations and done operational research on how you deliver those effectively. I wonder whether the panel could tell us whether there are any ideas as to how we get around that for TB.
Very good. Thank you for that. Anyone else want to come in at the moment? Yes? That microphone wasn't working. Just... I'm sorry, because I was sitting here, I didn't realize it wasn't working down there. Well, here, have another one. Use this one. Just go for the absolute... Just repeat the absolute center of your question.
Okay. So I will repeat the rant. Ibrahim Abubakar, Head of TV for Public Health England. I think that a quandary for us is the conflict between the sheer amount of competition that happens within academia in terms of whoever discovers the compound or gets the big Lancet or Nature paper gets all the credit, and it's similarly true for industry. Whoever gets the compound that is used gets all the profit. How do we get people to work together in concrete terms as opposed to just the aspiration that everybody agrees with? And I mentioned that the HIV lot seem to have done quite a good job of that, and I wonder whether there are lessons there.
Very good. Thank you very much. Your question was well worth repeating, because it goes straight to the heart of one of, I think, probably the big difficulties here. Let's go right across the panel. We finished with you. No, could you want to come in on this one quickly with a thought? I'm going to bounce it right along the panel. I think everyone...
Yeah, thank you, Ibrahim. It sounds like you have the answer yourself, so maybe you want to come back and tell us your own view on this one. In terms of getting the credits and getting patents for new discoveries, I'm not really the person to answer for that, but I can share some ideas, and this is something that is in this, this framework for operationalization of the research pillar of the new strategy, which is, put simply, it's about better collaboration. It's about mapping out who's doing what. So if you take the European context, who does what in Europe on the various research questions that we have identified, actually since many years back, that needs to be addressed, and see if you can establish a bit more collaboration and a little bit less of competition. If you think about the big EU funding opportunities, for example, obviously there is competition, but and it needs to continue. But are there ways to have more collaborative approaches there? But then there is also the domestic funding. And here I think there is an opportunity, because each researcher and institution have access to some domestic research funds that usually are not available for the competitors from other countries. And joining in a consortia that is tapping into research funds from each country, and then pooling it, or just sharing protocols and doing cross-country studies or multi-center studies, that is one possibility. And we are discussing that at the moment with several colleagues in the room, for example, around the theme of screening TB, both latent and active TB, among immigrants from high burden to low incidence countries in Europe, as a very important research field that needs a lot of work. And there we are thinking about exactly this approach, using the domestic funds, and then in the next phase go to a common research proposal, to the European Commission if that kind of call comes out that allows it.
Thank you. Manika, I see you have the microphone poised, ready to leap in with your view on this. Please.
Okay, I'm going to try and make a few comments on what you've said. First of all, it's not really, and this is a former clinical trialist and drug developer, I don't think it's easy to compare HIV to TB. The scientific challenges are very different. And I think some of the solutions that have been put in place in TB, in HIV can be used in TB, but we also need to think about different ways of doing things. Secondly, I'm a strong believer in that if something doesn't work, don't try and make more of it, or don't try and do more of it. So, you know, the current business model that we have generally for R&D, drug development, for instance, it doesn't work for TB. We know it doesn't work because we see the outcome of it. So trying to just reinforce that and do more of the same is not necessarily the answer. I think we need to find a different construct of how we need to do this. And in actual fact, I want to tell everyone in the audience here, there's been, 10, 15 years worth of policy thinking put into this, where you need innovation, you need access, and you need conservation, and where the access and conservation may be deterrents for the traditional forms of how we incentivize innovation. For instance, TB is, antimicrobial resistance is a very big topic at the moment. TB is, and particularly MDR TB, is par excellence an example of that. And we should be using a lot of the policy thinking around AMR on some of the models that are being proposed, different business models, that will promote innovation, will promote access, will promote conservation. And I'm very engaged in that community who are in that discussion. And to emphasize, this discussion is very old. It's not a new discussion. There has been committees and working groups formed by WHO that have reviewed hundreds of different proposals and done a thorough analysis of all of this. So let's not pretend that this is an entirely new discussion. And the third point to make is that I think if you think about the R&D model as it is based on push and pull mechanisms. You have push mechanisms that currently exist as grant fundings, which was actually very considerable in the field of antivirals, more than a decade ago. And you have pull mechanisms, which are basically the IP patent system, granting you a monopoly, and a company can see a lucrative market with a period of exclusivity, and off they go. Well, as has already been pointed out by Frank, that doesn't quite work in TB. Also, we need to construct drug regimens. There are scientific challenges to overcome, etc., etc. So you need to look at the whole R&D value chain as areas where you can have competition, and there's areas where you need to have collaboration. And what we need to do is reinforce the pull element that doesn't really work in the model and develop it in a way that can succeed for TB. So, for instance, you can look at developing, incentives or payouts or prizes or whatever you want to call them at different parts of the value chain. Maybe not at the end with a monopoly at the end, because you need to think about access and particularly conservation and rational use of these products. But maybe you can put it at a different place in the R&D value chain, like somewhere at the middle where you can get an I&D, and after that you look at a slightly different business model where you can promote much more collaboration and data sharing and all of this. Particularly in the upstream, very upstream part, again, there are models that will promote data sharing and get companies and academic groups together to look at, drug acceleration models. That is actually been efforts being made to set that up. So I think we have the ingredients in place, and I think that the key is to bring a lot of these different elements together and develop a slightly, different framework on how we can reinforce, particularly the pull elements of TB, reinforce the pull elements, particularly in areas where it's quite weak and where traditionally the funding is quite low, and look at also different ways of doing it, as been mentioned by Lena. And lastly, then look at how those two elements will reinforce the pooling part, which is the data sharing, the knowledge sharing, the IP sharing, and all of this.
Okay, thanks. Frank.
Well, in fact, there is an example of I think, a reasonably successful thus far initiative to get industry around the table together with academia in design of new drug regimens. That's the CPTR, the Critical Path Initiative, which was initiated by the NIH, the Gates Foundation, and the FDA. So it's a US initiative. But I think it has thus far been reasonably successful in letting various companies work together. And actually, I think the idea is that they will sort of, their drug will be in a pool of drugs for a particular regimen for regimen trials, and they also work together on, for example, pharmacokinetics and pharmacodynamic studies. From the academic point of view, with regard to collaboration, I think one of the major problems in tuberculosis, if you want to really understand what the problem is and how it should be solved, you need long-term studies with larger number of patients. One of the problems we've been faced with is that research funders usually they don't want to fund infrastructure. So what you basically need then is, for example, large cohort studies or community-based studies in which you would, for example, look at transmission and determinants of that, which is, in a sense, an investment in infrastructure in which you can pool various groups with their very specific capabilities to answer specific questions. And that has been very difficult to do. We actually, a couple of years ago, under the auspices of WHO, the Global TB Department, put together a number of major research funders around the table to discuss this issue, and they were very reluctant to do this because I think they perceived it as giving up their autonomy. So I think that's another thing that we should think about, how collaboration in that sense could start.
Thank you. A challenging question. I think there are three parts to it in my mind you raised. One is about actually issues around research that involves the development of new pharmaceutical products or intellectual property. Another one which is around academic competition. And the third one, which is about the type of research that actually we do need to fund. And so to pick up the first one, pharmaceutical products, I think there are now, broadly speaking, as we're faced with not just in TB, but with antimicrobial resistance as an issue across the board, we need to look at new ways of funding and encouraging research and product development in industry. New classes of antimicrobials, the first thing we're going to want to do, we're going to restrict their use. So it's not going to be a major money developer for industry, so there just needs to be a new way of thinking about that. But I think one of the things, more broadly speaking, is that publicly funded research, and increasingly even new pharmaceutical product development, is being funded partly, if not wholly, by public funding. I think the intellectual property rights there need to clearly sit with the funders there. So I think that there are models there, but I think there's a lot more work needs to be done, and it's not unique to TB, that issue. Academic competition, well, I could just sit here and pull my hair out, but I haven't got much left to pull out. But I think that one of the issues there is that we've talked about collaboration. We've talked about collaboration in research. That might help, but perhaps more global collaboration in funding may also help in that respect, in as much as there's still competition, but you don't get duplication. If there's a clear, coordinated global approach to funding major research, then there will be competition, but there won't necessarily be duplication, which I think is what is so wasteful in that respect. And the third point I'd make in response to your question is that is about the types of research. And I think this picks up what Knut was saying earlier on, and my colleague Frank has just said, is that there's a huge amount of work that needs to be done in terms of operational research. Achieving the 2035 target, that's not going to be through the application of new drugs and new vaccines. They simply won't be in the market long enough, if at all, by then. We're only going to do that by actually doing what we can already do better. And that's operational research. So I don't think there's quite the same challenges around intellectual property there. And I think what we do need, as the point, is the infrastructure. And I think we need to be thinking about how we can fund and assist, because a lot of that operational research probably needs to be done in high-instance countries where there's often a low GDP country as well. So how do we actually get the infrastructure developed to do that? It's not quite answering your question, but it gave me an opportunity to say it. Thank you.
Thank you. Lina.
Yeah, it's difficult to add something new, but what I want to stress is certainly that I think scientific competition is healthy, and we should make sure that we are not killing that. So what we need to find is the right balance between freedom of research and finding ways of how we can share the data, the results of moving forward together. And so I gave this example of the Global TB Vaccine Partnership. Some knows that this has been on the way for some years. But it also demonstrates how difficult it is, and I strongly believe that we can only succeed if we really get the backup from the scientific community, because it's not funders who is going to dictate the way forward. If we don't have the buy-in from the scientific community, who at the end is the ones that are going to do the research, they have their right to do their career. That is how things work today. And so it's a complex issue, but hopefully we will try to get there by working together. And I also agree that we indeed need to work globally together.
Okay, thank you for that. Do you want to throw in a quick thought there, Tonka?
We recognize that we need good partnership and good collaboration, but in the same time we need financial support because TB research is very complicated, and once again I would like to support collaboration.
Okay,
Between researchers and not only globally but in national, regional level.
Okay, thank you for that. Other people in the audience want to throw something in? There is someone there, right at the back, with a microphone that works, if possible. Otherwise, you will have to project, like Laurence Olivier.
I'm Paul Sommerfeld from TB Alert in Great Britain, and also from the TB Europe Coalition. I'm really stirred by a comment that Knut Lönnrot made towards the end of his introductory presentation, saying that what we need, one of the issues we need, is not just new tools, but new ways of getting them out, and therefore much greater support for patients through the period of treatment. But where I began to get worried was, Knut, you were also then going on to say we need more research into how to get more support to people in the community. And it seems to me that this conference as a whole, one of the areas that I would feel happy about at the end is if this conference was understanding this is not really an area for great new research. This is an area for some serious action in terms of understanding that it is civil society, local organizations that provide a tool to do exactly what Dr. Lönnrot was saying. And I would add, looking at the panel here, I particularly make reference to Bulgaria and Dr. Tonka Valeva, who I think has produced probably the best example that I know at the moment of good practice of building a system whereby there is systematic contracting of civil society and putting them in partnership with a cohort of so-called patronage nurses. And that system in Bulgaria is, I think, an extremely good one, well worth looking at. And generally my comment, though, to the panel is say more about what civil society, which already exists, can do if they're given a little bit of recognition and a little bit of money.
There we are. Good question. Good applause. We need some good answers. I'm going to also, I see if anyone else, there's a hand up there. Let's take another one because we've got 20 minutes left, but time goes fast. Please, microphone up there. Let's throw that question in as well.
Good morning, Claudia Carvalho from Portugal. I'm an infectious diseases doctor, and I also do research in public health. And I was very happy for this last intervention. And my comment goes exactly on that direction, because it's true that we do need to have some more operational research, and to not to only to expect by a magic bullet that is coming to solve everything. Because if we don't know how to make that accessible for patients, then it won't be of value. And I would also invite you to see a little bit of the study that we performed in Porto, exactly trying to describe some models of integrating care, particularly for people who use drugs. And so to integrate services like opioid substitution therapy with TB treatment, HIV treatment, and although it is very difficult for us as working in the field as clinicians to have time sometimes to describe some local experiences and some programs that can work well. So it's really also important to try to get some public health resources into the field to help to get to know and to publicize and to share that knowledge, because all over the world we know that there are very good examples and we do need to get to know them better and to share experiences. Thank you so much.
Thank you very much. And there's one just in front of you, yes.
Hello, do you hear me? Yeah. Thank you. My name is Dasha Ochiret. I am from Eurasian Harm Reduction Network based in Vilnius. And my comment and question would be really very much related to the previous two. So it's about resources for the civil society, because there was an example of Tomsk mentioned here, but actually the work to improve access to TB diagnostics and treatment and to go together with clients during these months and months in treatment was provided by NGOs. And today these NGOs in Russia and in other countries of the region suffer from being significantly underfunded. And we know that the same organizations provide care and prevention for HIV and for hepatitis C, etc., etc. So in terms of partnership, we will hear the voice from our colleagues and friends working in TB area when we advocate for more resources for civil society groups to work with vulnerable populations, including people who inject drugs. So that's my first question, I think very much related to the first and the second comment. And also we would like to see more partnership in terms of and engagement from this field into drug policy reform, because we know that even when we have wonderful tools and even when we have enough financial resource, if people are just put into prisons for years because of drug injecting, having no services there, then we cannot cope with TB in the European region. Thank you.
All right, thank you for your question. Well, I'm going to bounce all of those off the panel, and because we've got, in fact, 15 minutes left, I'm going to throw in a couple of thoughts of my own to ask them to bounce off them, so that you can treat these interventions perhaps as your closing remarks as well, as you take on board what they've said. My particular concerns are, because our job with this panel, and I take the points, of course, about civil society and integration and access and so on, they're very important. They're not absolutely quite central to the discussion of research and development insofar as we've been discussing it so far, but I think they're perfectly legitimate. But in terms of the core exercise of this panel, which is research and development, I wonder whether you all feel, after the discussion we've had, that the key area of difficulty, the key issue, the key problem is collaboration, because it keeps coming up in lots of different guises in what everyone says. Is it really the key barrier, the key difficulty? Or if not, what are other key difficulties or barriers that you feel are standing in the way of the advance that everyone's hoping for in research and development? So that's one thing I'd be grateful if each of you would pick up in your closing remarks. And I'd also be glad, since the essence of this meeting, as we see, is the Eastern Partnership Ministerial Conference, and we haven't had time to take on board that aspect of it very much, but if any of you would like to include any observation on how the specific Eastern Partnership aspect, the particular difficulties of the countries to the east of the European Union that are here, many of them represented, have an aspect that you feel should be alluded to in this discussion of research and development, I'd be very glad to hear it. So there, with my instructions, guidance, gentle hints, prodding, I'm going to start at the other end. Lena, I'm going to start with you this time. Give us your closing remarks. You each have about, since there's 15 minutes to go, then we have about 3 minutes each, roughly speaking. And I will interrupt you if you go over that, because I'm a rude sort of fellow anyway. I won't throw water over you, but I will interrupt you.
Yeah. So, indeed, we have been talking a lot about the tools that needs to be developed, the diagnostics, the vaccines, the drugs, etc. But just to reply maybe to one of the questions, the other actions that the Commission is also funding, actually also in my own unit, is public health research. And we have not mentioned that so much, that actually we also need to look into how can we best construct our health systems so they meet these needs. And coming back to your question, actually at the moment a number of EU member states are on the way of setting up a collaboration between the member states to work jointly together on health systems research, so what we also called the ERANETs. And here I can only encourage also the Eastern European countries to join this effort, because that is really also how you get into the research community and to the collaboration, and indeed can get the experience and share your experience with the other member states. So in public health, we do a lot of effort in actually using Europe as a kind of living laboratory, because each country, as you know, work very differently, have different challenges, but that is also an opportunity for research. So I don't know if it answers your question, but at least it gives you one idea of how we can bring in the Eastern European countries into our activities.
No, very useful, thank you. And in any case, we operate here according to those democratic principles at the heart of everything in Europe, including DG Research. So you choose to answer which aspects of the questions you like. Thank you very much for that. Mike, in the democratic spirit of WHO, perhaps you'd like to give your views.
Or even from the European Centre's perspective. Is collaboration the key difficult? Collaboration is key to getting the answer right, and I think what I would say it's collaboration both on the part of those undertaking the research through research consortia, but also collaboration amongst the funders. I mean, I do think that the global initiatives that we've heard about are going to be important in that. But no, collaboration isn't the only issue, and I come back to the point I made before, that I think that actually a major issue is about getting the right level of resource, the right level of funding for this, and that's about advocacy, and this is where I will seamlessly draw in the civil society point again, because I think that actually partnership with civil society is going to be really important in that, and we've seen the impact that can have, and I'm sorry to mention HIV again, but I mean I think that actually that relationship with civil society has been so important in getting HIV on the map, getting the funding flowing. So I see working with civil society as really important, but I would say that it's a two-way street. That actually, yes, the organisations that are represented on this panel here need to be reaching out to civil society, but I think that civil societies also need to make it very clear what the offer is that they bring to the table, to make it easier for organisations to know how to interact and what value comes from it. So I would say that actually collaboration is really important, but also getting the funding levels right is just as important, and I think part of that is about partnership with civil societies.
Thank you. Frank.
Yeah, I wanted to comment on the civil society issue as well. I think you're very right with the remarks that we just made. But I don't think there is a contradiction here. I think if it's an NGO develops a wonderful model for care, then I think the big question is, can we bring that to scale? And that means that you have to study a couple of things. You have to make sure that it is effective, that it is affordable, and so on and so forth. And this is, I think, really the area where academia and civil society could work together. And I mean, hearing that for example, the EC as a funder is interested through public health funding these kind of initiatives. So I think this is the kind of collaboration that is really important. The other thing, specifically for the Eastern Partnership countries, I think that there is now this document that Knut already referred to that is now coming out for the NTB strategy with regard to research, specifically mentions the importance of forming country research networks on TB that also have representation from the government, from national TB programs, national reference laboratory, and in which both civil society and academia and may also be industry are represented, and that they come up with a country-specific research agenda, which actually says these are our major problems, these are the things we need to know, and who can do that, and how do we then fund it? I think that is, we have worked in a couple of other countries in Asia and Africa with this same model. I think it has been very successful, and I think this is one of the concrete steps that can be taken.
Okay, so first of all, just to start by saying that I work for a very operational organization. We just get stuff done. That's our motto. So I very much kind of support the idea that we need to have much more operationalizing of already established strategies, including the introduction of new tools. In fact, we actually released a report out of STEP in the fall of last year, and as probably some of you probably read, we'd circulated a letter highlighting, in fact, that quite a lot can be done already to move implementation forward, and we actually see civil society as being a major partner in that. So I want to reinforce very much our support for that, and that's something that we feel extremely strongly about. Now, I want to make two comments partly related to that. First of all, and this is where I think civil society can play a very important role, we need to integrate our thinking when we talk about innovation, access, and specifically also conservation of things like TB drugs. The reason why I say that is because we have to stop, I think, a kind of playing off all these different elements together. I know that the pot of money is finite, but we have to think of a kind of integrated approach, tying in the research and development and operational research and innovation aspects to, I think, the parts that are about operations and service delivery and about access and about the rights of individuals and patients. And I think this is where the HIV model has been highly successful in the broad sense. And I think this is what we need to do in TB. We have to stop saying, put the money here instead of here. Particularly when you look at research and development for new tools, my biggest worry is in 10 or 15 years we'll be having exactly the same conversation. Why? Because 15 years ago I was having exactly the same conversation. And I can tell you, in TB we have made some progress, but the progress has been very limited. And part of the problem is because the access and the innovation are seen as two completely different separate pillars, and they're not. We have to integrate them. Which leads me to my third point, which is about the business model. And I would emphasize very strongly that we have a failed business model in TB. That's why we have a problem with innovation. That's why we have a problem with access. That's why we have such a tough time finding different alternative models of care. I've been in the field. I've actually set up TB programs, in conflict countries. It's damn hard. All right? You can innovate as much as you like. You will get up to a ceiling in what you can possibly do. And I can tell you, if it's hard for me, it's 10 times harder for the patient who's on the other end. So, I think there's a huge amount we can do to push things that we can do, but we also have to accept with what we have, it is utterly insufficient, and we need to find a different way of how the business model of research and development. And make a very, very strong plea today, because I just think, that we keep doing same of the old stuff. We keep adding things incrementally. We're not going to break out of this cycle unless we start doing things differently.
Okay, thank you. Yes, please, Knut.
Thank you. I'll finish with two main points. The first one is coming back to great comments about, I take it as implementation research and getting things done. I get extremely unhappy, actually, when health systems research and social science is pitched against real research, new tools, new diagnostics, medicines, and vaccines. It's part of the same continuum. And it's not that research only happens in laboratories. Certain things, we know what models work, and it's about operationalizing them, just getting things done. But there are a lot of things that requires proper research, not operational research, proper research to understand what models of care work best. Take the example of screening, as I mentioned before, screening immigrants from high to low incidence countries. A lot of countries in Europe, especially the low incidence countries, are struggling now with understanding what is the best policy, Who should be screened? How should they be screened, for latent TB or active or both? What is the best modality of ensuring pickup of the screening, follow through for the diagnosis, and ensuring completion of treatment? There are a number of questions there that needs to be addressed through research. So we need to pursue the whole continuum from the basic down to the operational. No question about it. How do we get it done? How can we move this field forward? I share the worry that we will have this discussion in exactly the same way 10 years from now. But let's hope. I mean, we're sitting here, people are thinking and discussing and getting to action points in many places. Let me finish with the action framework that we will finalize within a month, I hope. It has two main streams. One is sort of the bottom-up approach, where, as Frank was mentioning, we want countries to develop their own national TB research strategy as part of their national TB strategy. That should define the research agenda for that country and identify the most pressing research questions. It should also be a tool for networking and establishing the research collaboration within each country. That will help to inform the global agenda. And that's the second stream. The global work, which is about collaboration, it's about avoiding duplication, it is about, when appropriate, pooling resources and brains, and avoid unnecessary competition when it's not healthy. So that is what we're going to pursue. And on the country level, we have already identified what we call as a couple of model countries that are going to kick off this work this year, and hopefully by the end of the year have a couple of concrete examples of how that can move.
Very good. Thank you very much. Tonka, my co-chairman's closing remarks.
My colleagues, my friends, I strongly believe that elimination of TB is possible. But we really need a good collaboration, joint, integrated services to people living with TB. And of course, we need new diagnosis, new drugs, new vaccine. And in the end, I would like to say that we need very strong collaboration with NGOs and patients living with TB. Thank you.
Okay, well, thank you very much for that. And Europe is very good at talking, as we've demonstrated, and let's hope we don't have to wait 15 years to come back to the same conclusion as Manica reached, that we do this every 15 years. We look forward to action. We in the media on the outside will be watching. I would ask you to thank the panellists in the customary fashion for their interventions, and thank yourselves for your attention.
So, all right, ladies and gentlemen, now we have finished the first panel and our discussion session. I would like to thank once again our brilliant co-chairs and panelists for facilitating this discussion. And that brings us to the lunch, and lunch is served in the dining area across the hall. There will be 2 tables with the meals, so please don't gather at the doors and go further inside. You have almost 2 hours, but please come back at 2:45. And one more thing for your attention, there is another side event going on during lunch, workshop on EU health program, TB and HIV actions, organized by Consumers Health, Agriculture and Food Executive Agency, with participation of the representatives from European Commission, ECDC, Global Fund, WHO, and EU HP funded experts. This side event will be held in the Hall Eura, just on the left in the center of Austrumu, where coffee break was served, and the working language will be English. Please note that the light meal will be served there as well. So thank you very much, and meet after 2 hours.